Introducing frontotemporal dementia from a neurological perspective. Frontotemporal dementia is a neurodegenerative disease affecting the frontal and temporal lobes, causing debility to memory, language, and behaviour. It is the second most common form of early onset dementia, with age of onset typically being before the age of 65. FTD is a clinical manifestation of frontotemporal lobar degeneration, along with progressive non-fluent aphasia and semantic dementia. The behavioural variant of FTD will be the focus of this presentation. The following is an overview of the types of FTD. Symptoms presenting include disinhibition, apathy or inertia, lack of empathy, social disinterest, dietary changes such as binge eating or overeating, compulsive behaviours, and executive function deficits. Behavioural changes occur late in the disease, and the patient will often be oriented to time and space, however, have memory impairment in terms of inability to learn and retrieve information. They may also show late signs of Parkinsonism. BVFTD presents symptoms similar to those of Alzheimer's disease, among other illnesses, making for a difficult diagnosis. As such, a multidisciplinary approach is required. Neary and colleagues provide a comprehensive consensus on the clinical diagnostic criteria of FTD, including diagnostic features, supporting features, investigations, and exclusions. Considering patients present with symptoms at varying stages of the progressive disease, it is hard to compare patient-to-patient information. Imaging studies have previously revealed dominant alterations in the frontal structures and insula of early stages BVFTD. Magnetic resonance imaging, MRI, is used to detect expected atrophy in the frontal and temporal cortices. Protein inclusions are also expected. Electroencephalogram results are expected to be normal in early onset. Here is a list of the features as described by Neary and colleagues. Many of these features were described in the symptoms. So what neuroscience methods are used in diagnosing FTD? These include formal neuropsychological assessment, EEG, single photon emission tomography, positron emission tomography, MRI, and computed tomography. While neuropsychological testing is vital in an accurate FTD diagnosis, it is not sufficient in ascertaining a 100% diagnosis. This results need to be read in conjunction with the patient's behavioural and cognitive background. Assessments include the Addenbrooke Cognitive Examination, Frontal Assessment Battery, the Mini Mental State Examination, Clock Drawing Executive Test, and evaluation of mood disorders in accordance with the DSM-4. Neuropsychological assessment is useful in differentiating between other types of dementia such as Alzheimer's disease. They may rule out Alzheimer's disease, but may also be insufficient alone to diagnose FTD. They will be determining coinciding mood disorders or if a traumatic life event has taken place, often depression, which stage, i.e. phenocopy or probable FTD, as well as other contributing factors. EEG is expected to be normal for the patient's age despite evidence of clinical dementia. It is useful in ruling out Alzheimer's disease on initial presentation of symptoms, however should also be used baseline 2 and 3 month intervals on the administration of FTD medications. These include psychoactive neuroleptics, selective serotonin reuptake inhibitors, or choline steroids. Results will vary depending on age and stage of assessment of the patient. As people continue to live longer, we are seeing a marked increase in neurodegenerative disease. With definite diagnosis being most probable in autopsy, it is of increased importance to have the right combination of imaging techniques as soon as possible. Functional brain imaging is more marked in the frontal or anterior lobes, with abnormalities either bilaterally symmetric or asymmetric. Imaging also rules out other probable diagnoses of brain tumour, stroke, trauma or infection. MRI is used to detect atrophy predictive of executive function impairment shown early in the disease. Due to a lack of discernible white matter features in MRI, diffusion tensor imaging is becoming increasingly popular. PET can be used with 18-fluorodeoxyglucose, where MRI has not detected grey matter atrophy. The following is an image of the major brain areas associated with BVFTD. Rivas Nieto's study indicated SPECT findings related to depressive symptoms and CT mostly normal with 38.1% having cortical atrophy. These results are depicted in the following table. FTD can often go undiagnosed due to symptoms appearing similar to those of another condition. This includes apathy, loss of emotion and disinterest, which is often mistaken for depressive behaviour. Memory is actually an exclusion symptom, which appears in Alzheimer's disease. Creutzfeldt-Jakob disease or Huntington disease may develop and mimic FTD with symptoms such as fatigue, sleep disorder or appetite loss. As mentioned previously, issues such as head injury, metabolic disease and genetic disorders need to be ruled out, thus the need for a multidisciplinary approach. A different test needs to be used per symptom, making it challenging to reach a prompt diagnosis. It's not always easy to determine subtype when differentiating symptoms are not present. Subtle symptoms are often mistaken for depression or dismissed altogether. Comparison of symptoms is difficult as the age of onset is often unknown or differs greatly between patients. Patients considered possible for BVFTD often do not show typical neural markers, thus neuroimaging is required across time. FTD can take time to diagnose, particularly if patients and caregivers put up with the early symptoms before seeking treatment. It is important to work on a case-by-case basis of continued testing and evaluation to ensure the best outcome for caregiver and patient. In conclusion, diagnosing FTD is a multi-specialist process. All test results need to be considered in conjunction with the patient's behavioural and clinical history. This allows for an appropriate plan of action for both patient and caregiver, ensuring optimum quality of life.